Hello everyone, today we're going to make a tough topic simple. We are diving into the world of musculoskeletal medications. These drugs help our bones stay strong and our joints move freely. For anyone preparing for the NCLEX, this info is crucial. My goal, give you facts clearly and directly so you can walk into your exam confident. We'll break down each drug class, focusing on patient safety and test day success. Think of this as your essential study guide, cutting through complexity. Exam first approach, prioritizing the details most likely on your test. We'll cover bone disorders like osteoporosis, gout, rheumatoid arthritis, osteoarthritis. For each drug, we'll look at how it works, why it's used, and the critical nursing checks you must perform. We will use simple terms. Drugs for bone disorders, calcium, vitamin D, bisphosphonates, selective estrogen receptor modulators. Drugs for joint disorders, DMARDs, example, hydroxychloroquine and uric acid inhibitors. Let's start with the absolute foundation of bone health, calcium. Calcium is the primary mineral that gives our bones their strength and structure. When the body doesn't get enough, it can lead to conditions like osteoporosis, where bones become weak and brittle. That's where calcium supplements come in. The most common examples you'll see are calcium carbonate, calcium citrate. These are prescribed to treat hypocalcemia and to prevent or manage osteoporosis. They provide the raw material your body needs to maintain a strong skeleton, muscle contraction, nerve signaling. So, how do these supplements work? It's quite straightforward. They directly supply the body with elemental calcium. Once ingested, absorbed in the gut, enters the bloodstream, transported to the bones for storage or used for other physiological processes. Calcium carbonate requires stomach acid for good absorption, so it's best taken with food. Calcium citrate does not depend on acid. Can be taken anytime, which is a key point for older adults who may have less stomach acid. Now, let's talk about what can go wrong. Common side effects are gastrointestinal, constipation, bloating, upset stomach. The more serious concern is hypercalcemia, too much calcium in the blood. This can cause muscle weakness, confusion, fatigue, kidney stones. It's a serious adverse reaction that requires immediate attention. Another key point for the NCLEX is drug interactions. Calcium can interfere with absorption of other meds like tetracyclines, fluoroquinolones, as well as thyroid hormone replacements. As a nurse, your role is critical. You must monitor your patient's serum calcium levels to prevent hypercalcemia. Always assess their kidney function, as the kidneys are responsible for excreting excess calcium. Teach your patients to take calcium carbonate with meals to enhance absorption and reduce stomach upset. Advise them to separate their calcium dose from other medications by at least 1 to 2 hours to avoid interactions. And don't forget to encourage lifestyle measures that support bone health, like weight-bearing exercise and ensuring they have enough vitamin D, which we'll discuss next. Think of vitamin D as the key that unlocks the door for calcium. You can have all the calcium in the world, but without enough vitamin D, your body can't absorb and use it effectively. This is why vitamin D is so essential for bone health. It's prescribed for vitamin D deficiency, a condition that can cause rickets in children, osteomalacia in adults, both of which involve soft, weak bones, cholecalciferol, vitamin D3, ergocalciferol, vitamin D2, calcitriol, the active form used in patients with kidney disease who cannot activate it themselves. The mechanism of action is beautifully simple. Vitamin D stimulates absorption of calcium and phosphate from the small intestine. It works with other hormones to regulate calcium in the blood, ensuring enough is available for deposition into the bone matrix. Bone mineralization makes bones hard and strong. Without adequate vitamin D, calcium passes through the digestive system unabsorbed, leaving bones vulnerable. Vitamin D is absolutely necessary for building and maintaining a healthy skeleton. Taking too much vitamin D can cause problems. Common side effects include nausea, vomiting, constipation, often from increased calcium absorption. Major adverse reaction, hypercalcemia. Excess vitamin D can push calcium into a dangerous zone, causing weakness, confusion, kidney problems. Drug interactions. Thiazide diuretics can increase hypercalcemia risk. Some anti-seizure medications can decrease vitamin D levels. Nursing responsibilities, monitoring and education. Monitor serum calcium, monitor vitamin D levels via regular blood tests. Patient teaching is huge. Educate your patients on the importance of safe sun exposure, as sunlight is a natural source of vitamin D. Dietary sources: fatty fish, fortified milk, cereals. Advise taking vitamin D with a meal that contains fat to improve absorption. For the NCLEX, remember, calcium and vitamin D work as a team. Now we move to a powerful class of drugs called bisphosphonates. These are the guardians of your bone density. Think of them as the security guards that stop thieves from stealing from a warehouse. Warehouse eals your bone. Thieves ex osteoclasts that break down bone tissue. Drugs in this class, such as alendronate, risedronate, ibandronate, are first-line treatments for osteoporosis and for Paget's disease of bone. Their primary goal is to slow bone loss and reduce fracture risk, especially in the hip, spine. The way bisphosphonates work is by inhibiting osteoclast activity. They bind to the bone surface, are taken up by osteoclasts during resorption, and disrupt osteoclast function, causing inactivation or apoptosis. Osteoblasts then catch up, tipping balance toward bone formation. Over time, bone mineral density increases and the skeleton becomes more fracture resistant. While effective, these drugs have specific side effects and administration rules high yield for NCLEX. Most common, esophageal irritation, heartburn or difficulty swallowing, rare but serious, osteonecrosis of the jaw, atypical femur fractures. Patients must know these risks. Calcium, antacids significantly reduce absorption. Patient education is non-negotiable. Take first thing in the morning on an empty stomach with a full 8 oz glass of plain water. Remain sitting or standing upright for 30 to 60 minutes after the pill. Nothing else should be consumed during this time. Before long-term therapy, get a dental checkup. Monitor bone density scans and kidney function routinely. Next up is a clever class of drugs known as selective estrogen receptor modulators, SERMs. They selectively modulate estrogen receptors in different parts of the body. Key example for NCLEX, raloxifene, used for the prevention and treatment of osteoporosis in postmenopausal women. It offers a targeted approach, bone protective benefits of estrogen without stimulating other tissues. Breast, uterus, concern with traditional hormone replacement therapy. Raloxifene acts as an estrogen agonist in bone tissue. It mimics estrogen, binds receptors on bone cells, slows osteoclast-driven bone resorption, preserves bone mineral density, reduces risk of vertebral fractures. In breast and uterine tissue, raloxifene is an estrogen antagonist. No increased risk of breast cancer or uterine cancer. Side effects, hot flashes, leg cramps, most serious, increased risk of thromboembolic events, deep vein thrombosis, DVT, blood clot in the leg, pulmonary embolism, PE, clot to the lungs, life-threatening. Assess every patient for clot risk. Concurrent estrogen therapy generally not recommended. Nursing focus, risk assessment and patient education. Before starting, check history for prior blood clots, stroke, heart issues. Teach DVT signs, pain, swelling, redness in one leg. Teach PE signs, sudden chest pain, shortness of breath. Seek immediate medical help if these occur. Advise stopping medication during prolonged immobilization, after surgery, during long-distance travel, to minimize clot risk. Let's shift our focus from bones to joints. Tackle a painful condition called gout. Gout is a form of inflammatory arthritis caused by hyperuricemia, an excess of uric acid in the blood. This excess uric acid can form sharp, needle-like crystals in the joints, causing sudden severe pain, redness, swelling. To manage long-term, we use uric acid lowering agents. Goal: prevent future gout attacks and prevent tophi, large uric acid deposits under the skin. There are two main mechanisms: xanthine oxidase inhibitors, allopurinol, febuxostat. They block xanthine oxidase, cutting uric acid production. Uricosuric agents like probenecid increase renal excretion of uric acid into the urine. Both approaches lower serum uric acid to stop crystal formation. Common side effects: skin rash, gastrointestinal upset, but be vigilant for serious adverse reactions. Allopurinol, rare but severe hypersensitivity, including Stevens-Johnson syndrome. Febuxostat, black box warning, increased cardiovascular death in patients with heart disease. NCLEX, critical interaction, allopurinol increases azathioprine levels, mercaptopurine. This interaction can be life-threatening. As a nurse, start with a thorough assessment. Check renal function, check liver function, and screen for history of heart disease if considering febuxostat. Start medications at a low dose and titrate up to minimize side effects. Teach hydration. Drink plenty of fluids. This helps kidneys flush uric acid and prevents kidney stones. Advise patients to report any new rash immediately. While uric acid inhibitors are for long-term prevention, a different set of drugs is needed to manage the intense pain and inflammation of an acute gout attack. When a patient is experiencing a flare-up, the immediate goal is relief. The primary agents used for this are non-steroidal anti-inflammatory drugs, colchicine, corticosteroids. These medications do not lower uric acid levels, they target the inflammatory response from uric acid crystals. For the NCLEX, distinguish acute treatments from chronic preventive therapies. Each drug works differently to calm the inflammation. High-dose NSAIDs inhibit cyclooxygenase enzymes, reducing prostaglandins that cause pain and inflammation. Indomethacin, naproxen, colchicine prevents neutrophil migration to the joint. Corticosteroids like prednisone suppress the immune response broadly. Drug choice depends on comorbidities and other meds. Side effects are common with these acute treatments. NSAIDs, stomach upset, increased risk of gastrointestinal bleeding, kidney damage risk especially in older adults. Colchicine, gastrointestinal distress, diarrhea, nausea. High doses of colchicine can be toxic. Corticosteroids, elevated blood sugar, fluid retention, mood changes. NSAIDs can interact with blood thinners, increasing bleeding risk. Nursing care focuses on safe administration and monitoring. Now let's turn to rheumatoid arthritis or RA. Unlike the wear and tear of osteoarthritis, RA is an autoimmune disease, attacks the lining of the joints, the synovium. This causes chronic inflammation, pain, and eventually irreversible joint damage and deformity. The cornerstone of treatment is a class of drugs called disease-modifying anti-rheumatic drugs or DMARDs. The goal of DMARDs is not just to relieve symptoms but to slow down or stop the disease process itself, preserving joint function and preventing long-term disability. There are two main categories of DMARDs, traditional and biologic. Traditional DMARDs have been used for decades. Methotrexate, hydroxychloroquine, sulfasalazine. Their exact mechanisms vary, but they generally work by broadly suppressing the overactive immune system. Methotrexate, the most common first-line DMARD, interferes with the metabolism of immune cells, reducing their ability to cause inflammation. Biologic DMARDs are newer, more targeted therapies. Etanercept, infliximab, adalimumab. They are genetically engineered proteins that block specific components of the immune system like a substance called tumor necrosis factor, a key driver of inflammation in RA. The side effect profiles of these drugs are a major focus for the NCLEX: nausea, fatigue, liver damage, bone marrow suppression, leading to low blood counts, lung problems. Hydroxychloroquine is generally well tolerated. Rare but serious risk of irreversible retinal toxicity with long-term use. For biologic DMARDs, the primary concern is an increased risk of serious infections. They can also cause reactivation of latent infections like tuberculosis. Your nursing care is all about safety, monitoring, education. Before starting therapy, baseline laboratory tests are essential. Complete blood count, liver function tests, kidney function tests, screening for tuberculosis, screening for viral hepatitis. For hydroxychloroquine, a baseline and periodic eye exams are required. You must teach patients on any DMARD about the risk of infection. Report fever immediately, report sore throat immediately, report cough immediately. Avoid live vaccines, practice good hand hygiene. Finally, let's discuss osteoarthritis, the most common type of arthritis. This is the wear and tear arthritis. Protective cartilage cushions wear down over time. Unlike RA, OA isn't primarily autoimmune or inflammatory. Some inflammation can still occur. Main treatment goal: manage symptoms, primarily pain, and improve or maintain joint function and quality of life. Pharmacologic approach is stepwise, starting with safer options and moving up as needed. First line for mild to moderate OA pain: acetaminophen. Acetaminophen is an analgesic and antipyretic, thought to work primarily in the central nervous system. If acetaminophen isn't enough or inflammation is present, use NSAIDs. Ibuprofen, naproxen, NSAIDs block cyclooxygenase enzymes, pain relief and anti-inflammatory effect. For severe pain, Topical agents, joint injections, stronger prescription pain relievers in some cases, no side effect profiles, acetaminophen concern, liver toxicity, risk increases with high doses, chronic use or alcohol, never exceed the maximum daily dose, NSAID main side effects, gastrointestinal issues, stomach upset, increased risk of peptic ulcers and gastrointestinal bleeding. NSAIDs can negatively affect kidney function, increase blood pressure, and raise risk of cardiovascular events with long-term use. Risks are higher in older adults, the group most likely to have OA. Nursing role, safe dosing and patient education. Always assess history for liver disease, kidney disease, heart failure, gastrointestinal bleeding. Teach correct dosing for acetaminophen. Warn patients to check OTC labels to avoid excess acetaminophen. Advise taking NSAIDs with food to reduce stomach irritation. Tell patients to report signs of GI bleeding, like black tarry stools. Encourage non-pharmacologic measures first. Weight loss, physical therapy, swimming, walking. We have covered a lot of ground, so let's consolidate the most important high-yield nursing points you need to lock in for the NCLEX. Patient safety is always the top priority. Check for allergies and contraindications before any new medication. For musculoskeletal drugs, know who is high risk for gastrointestinal bleeds, kidney damage, liver toxicity, blood clots. Always review baseline labs, liver enzymes for methotrexate, serum calcium for vitamin D, tuberculosis test for biologic DMRs. These checks are your first line of defense. Master administration rules, classic NCLEX material. Bisphosphonates like alendronate, empty stomach, full glass of water, stay upright 30 minutes. Calcium carbonate, best with food. Calcium citrate doesn't require food. These steps prevent harms like esophageal burns. Patient teaching extends safe administration. Explain rules so patients can follow them at home. Vigilant monitoring is core nursing work. Be a detective. Watch for subtle infection signs on immunosuppressants. Report fever. Report sore throat immediately. No DVT signs for raloxifene. Unilateral leg swelling, leg pain. Recognize hypercalcemia, weakness, confusion. If a new symptom appears, connect it to meds. Hold the drug when appropriate. Notify the provider. Remember the big picture. Medications are one part of a treatment plan. Encourage non-pharmacologic strategies. Diet, exercise, physical therapy. On the NCLEX, breathe, think safety and monitoring. Choose the answer that best protects the patient. Focus on assessment, safe administration, education, and monitoring. You'll be ready for questions on bone and joint meds and to care for your patients. For more information, visit www.brispainternational.com.